Hi all, this is Maylene Velasquez. I am a licensed clinical social worker and a registered play therapist. I also specialize in perinatal and infant mental health. Today I was hoping to discuss treatment of young children in what we think of the field of infant mental health, which generally refers to children ages 0 to 5. One of the questions that I've seen online recently regarding this population is how do you engage young children in counseling? How do you keep them interested in what you're working on? And what kind of treatment do you provide? In the area of infant mental health, we tend to think that children thrive in the context of relationships. And so all the interventions that we provide and all the treatment that we give to families involves engaging the family. So if I'm working with a 3-year-old, I'm really working in the relationship or within the relationship of the parent and the child. This is how I manage to bridge the field of perinatal mental health and infant mental health. Because I think that just as children thrive in the context of their relationship, children to parents' mental well-being. As we think about the infant mental health population, my recommendation is always going to be to include the caregiver in the session. Engage them in activities that are going to be attachment based and relational, where you're using the relationship as a guiding principle and as the vehicle for strengthening the tools, coping strategies, and whatever goals that you're working with the diet. Of course, there's going to be situations where the parents' best interest might not be to be present in every session. For me, I make that recommendation only when the parent's level of distress is so high that they cannot be present for the child, specifically where trauma has taken place. However, if the parent is not available or if one of the parents is not available, I would engage another caregiver. The best way for you to be ready to work with the infant mental health population is going to be to obtain training in infant mental health. You want a thorough training that includes physical, social, and emotional development, training that teaches you about attachment, about how trauma shapes the infant brain, training that helps you to screen for developmental or emotional needs that the child might have in the event that there's other referrals that you might need to make, such as to a developmental specialist or an occupational therapist or a speech therapist. And then you also want to participate in reflective supervision. Reflective supervision is a type of consultation that infant mental health professionals engage in, where they get to explore the different feelings and emotions that come up for them as they're working with families. So as opposed to supervision where you focus on maybe specific tools and strategies to try out, or supervision where you focus on the administrative aspects of your work, reflective supervision transcends inward so that you as a clinician can become more aware, mindful, and reflective when working with families. Recognizing that what comes up for us is inevitably going to affect the quality of the relationship. And that working with such a young population, especially when trauma is involved, can lead to high levels of stress and place us at risk for vicarious trauma. So maybe as you think about what training and what supervision you're going to engage on, maybe you're already working with young children. Maybe you work in an organization that's giving you a caseload and you want some tools and strategies and kind of ideas as to what you're going to do with the family and how you're going to best support them. I'm going to show you some resources that I personally find helpful. When I first started, one of the things that was really helpful for me is to have a manual or actual tools that I can review and show the family. When working with clients with young children, especially perinatal clients that are experiencing levels of depression or anxiety or OCD or PTSD or any of the other mental health complications that can take place when a child is born, I find that it's very helpful to provide parents with tangible instruction that is reasonable and realistic that they can apply to their day-to-day lives.
Going into an office, working 50 hours a week.
All right, so welcome everybody. wanted to get back into the infant mental health assessment in that part of the book. So here is the chapter. So AIMS is an instrument used for assessing emotional well-being of children. That's from birth to 5 years old. So they assess attachment, interactions, mastery, and social supports. Also, one intervention for emotional development, you can show admiration for the baby's parents, the baby and parents' presence, point out the parent's ability to hear the baby, the child's cries, requests, and respond appropriately. Also discuss the role of the other parent in caregiving. And then finally, discuss upcoming stages of infant development. So a lot of times that's a good way to just lead into overall discussion if they notice what's going on with the kid. Like, he's going to be sitting up soon, like at 6 months, or he might be standing and then walking soon at 1 year, and going through all of those different things that you can with the kid. And that's a way to begin dialogue. And then finally, comment on how proud the parent must be to see the baby and child doing so well. And that's important, just to kind of create that dialogue, find ways that the kids are hanging in there, and find things that they're doing with mom and dad that would actually make it. And that is one of the first steps for early intervention. So other early intervention for developmental delays. In the 1970s, parents were encouraged to institutionalize babies with a developmental delay. This is where the video on Geraldo Rivera is a big deal, because he actually kind of broke into the scene and found where they were not caring for these folks. The intervention programs were then developed for infants with disabilities. So services with infants and toddlers with handicapping conditions, that was federal law. Most communities provide infant stimulation or early intervention programs, and then parents are taught exercises and activities to do with the child. Strengthening the baby's muscles enriches interaction with the environment and enhances cognitive and physical development. So let me shrink this down a bit because it's a little bit large. So GERALDORIVERA, disability accountability. So the disability case is this one, and it was called Willowbrook. And this is some of the stuff that they did back in the day that's there's a lot on Geraldo Rivera you can look up, and the asylum that he visited, and kind of told the whole world about.
Good evening, I'm Will Butel. The special report that follows is a story that started back in January of 1972, of the care and treatment the state provides for its mentally retarded people. The special report tells the story of the changes that have been made since 1972 and of the changes that have still to be made. The French have an expression, plus ça change, plus c'est la même chose. The more things change, the more they stay the same. Never has the expression been more appropriate than it is now. This is the Willowbrook case. Geraldo Rivera reporting.
This building in Brooklyn houses the Eastern District Federal Courthouse. And this room on the 6th floor for the last several months has echoed with the frightening recital of horrors. Federal Judge Orrin Judd has been hearing testimony on the case against the New York State Department of Mental Hygiene. To the people who've given testimony in this courtroom, this unprecedented federal lawsuit is known simply as the Willowbrook case, because it specifically concerns that warehouse of human misery on Staten Island. This court is hearing the story for the first time, but it's an old story, and a story that goes even beyond the locked boards at Willowbrook and beyond the case being argued. And we tell a larger story, our version of the Willowbrook case, the people against the state of New York. Robert Kennedy went to Willowbrook in 1965, almost 10 years ago. He demanded change, but there would be no change. We submit what he found as our Exhibit A, our first piece of evidence in the case against the state of New York.
I visited the state institutions for the mentally retarded, and I think particularly at Willowbrook that we have a situation that borders on a snake pit, and that the children live in filth, but many of our fellow citizens are suffering tremendously because of lack of attention, lack of imagination, lack of adequate manpower.
In 1972, we went to Willowbrook for the first time. These are the conditions we found. This is our Exhibit B. The first building we went into was number 6, the B ward, and I was totally unprepared for what we found there. In the large bare room, there was one attendant and perhaps 50 or 60 seriously and profoundly retarded young boys. Many of them were naked, some were smeared with their own feces, or were just rocking back and forth or smashing their heads against the floor and walls. This institution in 1972 was a crime against humanity. Those aren't just words, they accurately reflect the reality of Willowbrook. It was a horrible place that New York State officials could neither defend nor explain away. Since that time, however, some significant improvements have been implemented, and this documentary, among other things, is a follow-up on what has or has not been done. Willowbrook, as it was in November of this year, is our Exhibit C in this case against the state. Under the crushing pressure of public outrage, the Department of Mental Hygiene increased the institution's budget and added 300 staff people. It also took action to decrease the number of residents at Willowbrook, reducing the total population from 5 to about 3,000. But despite these improvements, the expert witnesses in the federal lawsuit testified that conditions for people who remained at the institution were as bad, and in some cases were worse, than they had been before the initial newspaper and television exposés, a fact indicative of either supreme incompetence or grossly misplaced priorities on the part of state officials. Under the heading of Exhibit D, we present some of the specific evidence of insufficient change. It deals mostly with the physical abuse or neglect of the residents, but is not meant as a reflection on the employees at the institution, most of whom are dedicated, underpaid, and working under impossible conditions. There have been several complaints from parents of apparently battered children.
How much more can he take? He can't speak to himself. I have to talk for him.
In October, an 18-year-old resident of Building 8 was found lying in a pool of blood next to his bed. Nobody saw what happened to him, but the night attendant quickly called for a doctor. At night, there's only one doctor on duty to care for all 3,000 residents. According to witnesses, it took the doctor 20 minutes to get from Building 2 to Building 8, a distance of about 200 yards. By that time, the resident was dead. This summer, another retarded child broke a leg. He was taken from Willowbrook to the Public Service Hospital on Staten Island, where a cast was put on. The child was then taken back to this ward at Willowbrook to recuperate. When he was returned to the Public Health Hospital to have the cast removed 3 months later, the nurses there were horrified to discover that the cast had been rotted by the boy's own urine. When the cast was finally removed, it was found to be infested with maggots.
By the time the maggots were found, it was too late because we did not get any answer from the public health hospital as to what to be done, and we immediately had them removed. But we certainly do admit that it should have been corrected, yes.
There are no screens on the windows of Willowbrook's hospital ward, so the limbs of crippled children are inviting resting and feeding grounds for flies. And open sores like this one, not really explained, have been seen too frequently in this place. I said earlier that about 2,000 residents have been taken out of Willowbrook. Good news, but where have they gone? While some have been placed in wonderful community facilities like those run by Catholic Charities and the Association for Retarded Children, the majority have just been shifted to other substandard institutions. Operation Exodus, the program to reduce the population of Willowbrook, is a failure because many of the former residents, like those taken here to Keener on Ward's Island, are worse off now than they were before they left Willowbrook. The Department of Mental Hygiene has the responsibility for caring also for the state's mentally ill as well as its retarded. And the department's record in this area leaves just as much to be desired. Pilgrim State is the world's largest institution devoted to the care of the mentally ill. Located out in Suffolk County, the complex of buildings is enormous. The wards are fairly clean now, but they're also depressingly familiar. They're filled with men and women doing nothing, going nowhere, waiting for nothing to happen. During the mid-60s, Pilgrim State, along with Kings Park, Central Islip, and other state institutions for the mentally ill, were the target of scandal and expose. They were branded human warehouses that were totally unresponsive, failing to provide either decent living conditions or rehabilitation for their residents. The critics said that the best way to care for the mentally handicapped was outside these big institutions and in the community. The state responded to the criticism with panic. They started almost indiscriminately to discharge patients. So many were set free that it permitted state officials to close down entire buildings, not only at Pilgrim State, but at Kings Park and at Central Islip as well. There are now dozens of structurally sound abandoned buildings on Department of Mental Hygiene property. This is Pilgrim State Hospital, and it's too bad it isn't Halloween because this is absolutely the spookiest place I've ever been. Behind me is what must have been one of the biggest buildings ever built on Long Island. It was put up in the early 40s. Actually, this place is like a little town. The big central building in the middle, the little church in the foreground, and lots of smaller buildings, satellites actually, to every side of it. All of them are empty. It's eerie here. It's like a ghost town. You wonder where all the people went. The answer to that question is our Exhibit H. It's called dumping. This is Main Street in the town of Bayshore, Long Island. Until recently, this was a pleasant, quiet suburban community. Its misfortune, though, is that it's located within a few miles of the big institutions. Because, as you can see, shuffling along the street at every hour of the day or night, improperly dressed, unsupervised, and uncared for, are dozens and dozens of former mental patients. In an indefensible perversion of the concept of community care, the state just put these people out, with little or no preparation, with little or no provision for aftercare or supervision or psychiatric follow-up. They were dumped out on the streets. A whole new business was created by the emptying of the institutions for the mentally ill, providing housing for former residents. Some of the community facilities are decent and well-maintained. Most are not. The dismal Bay Bright Hotel, where a majority of the residents are former mental patients, is an example. Until October, there were no rehabilitative programs here at all, and now they're only minimal. 2 men share 1 room. I asked the hotel manager about it. Lance, what rent does he pay here?
Pete pays $125 per month.
And the other roommate also $125. Right. So that means for this room they pay $250 a month.
Yes.
Don't you think that's high for a room that's maybe, what is this, 8 by 10 and 2 people, $250 a month, and that's without food, right?
That is without food, right? That's room by itself.
With $250 a month, they could live in a whole house. Don't you think that's kind of high?
No, I don't. That's the going rate.
In Wyandanch, also in Suffolk County, there's a rundown frame house that's been rented to 3 former mental patients. It demonstrates how badly the state has failed in the area of community care. This slum is owned and operated by an employee of the Department of Mental Hygiene, a residential therapist at Pilgrim State. The 3 residents of this house, all of whom were discharged from Pilgrim State, are charged a total of $420 a month rent for the privilege of living here. My guide was Richard Ballant, the social worker.
The health department was notified and they did contact the landlord, Mr. Powell. So he seems to be making some slight attempts, but the place you can see is still well, disgusting. And I'm aware of the fact that Mr. Powell is pulling in some $420 a month rent for this place, every 28 days, that is.
Mr. Powell was given the opportunity to come on and give his side of the story, but he chose not to. Long Beach in Nassau County is another community that suffered as a result of dumping. It used to be an attractive beachside resort, but the city had the misfortune of having an excess of hotels with empty rooms in the off-season. Enterprising owners got together with state officials and large numbers of former mental patients were shuttled in. One of the largest hotels on the boardwalk is the Promenade, where the normal elderly with their very different needs are now housed side by side with the mentally handicapped. My tour guide was Long Beach resident Joe French.
Problem is that they're here and you can see they just sit. There's no programs for their entertainment, for their diet, for their care, for their well-being, dress. And that's the thing that the people in Long Beach are concerned about, is that it may have been a great program to turn people loose out of these big institutions, but they just moved them from one institution to another where they get less care than they got in the institution that they were first in.
Do you want to tell me the story of the mental patient who was found dead after, well, I guess an extended period of time?
Yeah, I guess what happened is that seventh floor, the top floor of the hotel, was closed off and not used anymore. And all of the elevators don't run there, except there is one that runs to that floor. She must have wandered onto that elevator, went to the top floor, and no one ever goes up there. And then we don't know how she died. She died up there and she laid there for several months. No one went up there, so no one found it until some workmen happened to go up there one day.
I spoke with two residents of another establishment catering primarily to release mental patients, the Miami Hotel. Do they take care of you now?
No.
That's a question.
They don't come and help you out or take care of you?
No, they don't help us. That's any question. The truth, that's any question.
Well, there's a feeling of indignation at the State Department of Mental Hygiene at its poorly developed and improperly conceived program of releasing mental patients. It's thrust large numbers of people into Long Beach without proper aftercare. It's placed an undue burden on the community, and it's certainly totally unfair to the former patients themselves.
The Upper West Side of Manhattan is another area with more than its share of dumped mental patients, and again, there's a logical reason. In this case, it's the proliferation of sleazy single-room occupancy hotels, perhaps the sleaziest of which is the West Side Towers on Broadway, where living conditions like this are common. The occupant of this room, a released mental patient, ran in fear when we knocked on his door. There's a person lives in this room. Dr. Henry Brill of the Department of Mental Hygiene responds.
The operation has not been fully successful. With hindsight, it's apparent now that we could have done it differently. Under the pressures that existed at the time, legal pressures, that is the pressure of laws, regulations, public opinion, professional enthusiasm, I'm not sure that how it could have been done differently, but if I had it to do over again, I would feel that we could have done it differently.
Most people getting out of mental institutions need welfare benefits to survive. That's an unavoidable fact of life. The big political question, though, is who pays the welfare bill? The original county of residence or the county the former mental patient moves into after he or she is released from an institution? This internal memorandum and others obtained for us by the independent study group from the records of the Department of Mental Hygiene are clear and to us convincing evidence that under pressure from Suffolk County officials who are angry of the dumping of residents into towns like Bay Shore, the department unlawfully contrived to prevent patients released in Suffolk from getting assistance from that county. Brendan Bushy of the study group explains.
These people were cut off from the state and the county. They were denied resources at the welfare department and they were denied resources at the hospital. It meant that they had to go to
So here's
Geraldo
Geraldo
Rivera, and this is
Rivera
my friend
today.
Bernard Carabella.
And
Aside
that's
from the fact that
one
we're
of the
both
guys he actually
Latins from Manhattan with mustaches.
worked
Bernard
with.
and I.
And he kind of exposed a lot of the stuff that was going on there. And so when we look at in the 70s, parents were encouraged to institutionalize babies. That's really why they don't anymore. So if you're doing your genogram and writing things up, you could put in if something of that nature shows up for you and what it may look like for you. So also the next few slides, some of the biophysical strengths and hazards. So like trying to keep babies injury free from accidents, that can be hard. Illness susceptibility, breastfeeding helps with that. Also, sudden infant death syndrome is a big one that comes up. And then things parents must take preventative measures to like try to avoid. So in breastfeeding, the World Health Organization recommends exclusively breastfed for the first 6 months of life. So EBF. And that's where you get a lot of the stuff to prevent viruses. And, you know, the mom is passed between mother and child. And there's quite a bit on exclusive breastfeeding, as you can see here, and just why it's better. So there's quite a few. I'll show you guys one, and there's, if you did a search, you can find quite a few quickly.
So we know that exclusive breastfeeding is what's currently recommended for your baby for the first 6 months of life, and that's the only food that they need. The wonderful thing about breast milk is that it changes to meet your baby's growing needs. And your baby will let you know in that time how much milk they want. There may be some weeks where they want more, and there'll be some weeks where they want less. And that is the beauty about breastfeeding, is that the baby has control over how much that they want. So the benefits of breastfeeding your baby that we know is it's very good to provide protection against. It can also reduce the risk of allergies, and we know that breastfeeding can also reduce childhood obesity later in life. From 6 months, babies can start on solid foods because they do need the variety from those different nutrients development. So you can either express by hand, or you may want to use a pump, and there are manual and electric pumps available. We do suggest not to express straight after feeding because your baby would have removed the milk. So perhaps wait 30 minutes to 60 minutes after the feed, gentle breast massage to start, and you're looking at 5 to 10 minutes for each breast. Should be enough time for you to express the milk. You can store your milk at room temperature. Actually, for 4 hours is quite safe. It can be stored in the fridge for up to 3 days. We suggest to have it at the back of the fridge where the temperature doesn't fluctuate. And you can also freeze your breast milk as well. So you can successfully combine breastfeeding and going back to work. You might want to chat prior to your employer to see what support they're able to offer you, in particular where you would express and also where you could store your milk.
So you see some of the different pushes they have for breastfeeding, and it goes all over the world. So they even have a World Breastfeeding Day now.
His parents hired me to bring him out of his shell before college. Give you a skinny dipping. What about sharks? In here right now! This is gonna be harder than we thought.
Are you aware that World Breastfeeding Week is an annual celebration which is held every year from the 1st to 7th of August in more than 120 countries? Well, this year's theme is Step Up for Breastfeeding, Educate and Support. The theme is aimed at encouraging breastfeeding as a very important aspect in the early development of a baby. WHO and the American Academy of Pediatrics emphasize the value of breastfeeding for mothers as well as children. Those bodies also recommend exclusive breastfeeding for the first 6 months of life, and then supplemented breastfeeding for at least 1 year and up to 2 years or more. This provides many health benefits, critical nutrients, protection from deadly diseases such as pneumonia, and fostering growth and development on newborn.
And they even have some cartoons about it, like different commercials. So it helps kids with their immunity, helps mom with like lowering her challenges. It helps in several different ways. And then
remember to subscribe and don't forget to hit the bell icon to never miss an update from First Cry Parenting.
Importance of exclusive breastfeeding. Exclusive breastfeeding means that a baby is fed only breast milk for the first 6 months of his life with no additional food or drinks. This is the best nourishment for the baby, who is not even given water. We will now look closely at the benefits of exclusive breastfeeding and some important tips to consider. Benefits of exclusive breastfeeding for mother and baby. Number 1. Scientific studies have revealed that the healthiest babies are those that have been exclusively breastfed. Number 2. For the first 6 months of a baby's life, breast milk is all that a baby really needs. Number 3. Exclusive breastfeeding is one of the best ways to minimize the chances of a baby getting diarrhea, allergies, pneumonia, and suffering from malnutrition. Number 4. Exclusive breastfeeding is known to considerably decrease infant mortality on account of common childhood illnesses. Number 5. Exclusive breastfeeding delays fertility, assisting appropriate time intervals between pregnancies. Number 6. Exclusively breastfeeding mothers are less prone to cancer of the breast and ovaries. Number 7. Exclusive breastfeeding is also economical as it eliminates the need to purchase supplements and expensive formulas and equipment. Number 8. Colostrum in breast milk cleans the stomach and promotes a healthy gut, eliminating the need for medicines. Number 9. Exclusive breastfeeding helps the new mother to lose weight after delivery. Number 10. Mothers who breastfeed exclusively are less likely to experience postpartum depression. Number 11. The more a baby suckles, the more milk will be made in the breasts. This natural mechanism helps make exclusive breastfeeding a viable choice. Tips for exclusive breastfeeding. Tip number 1. Breastfeeding should be initiated within 1 hour of the baby being born. Tip number 2. Exclusive breastfeeding for 6 months is ideal. Tip number 3. The baby should only be given breast milk and nothing else, not even water. Tip number 4. Breastfeeding should be done as and when the baby demands. Tip number 5. Breastfeeding should be made possible by the mother even at night. Co-sleeping can help achieve this. Tip number 6. Nipple confusion should be avoided by not using artificial nipples. Tip number 7. It is advisable for the mother to read and learn about potential problems with breastfeeding. Tip number 8. Working moms can use expressed breast milk. Tip number 9. Medical staff, caregivers, and hospital authorities should be informed about the decision of exclusive breastfeeding. Tip number 10. Breastfeeding support groups can be very helpful for exclusive breastfeeding. Tip for her newborn baby. Exclusive breastfeeding is the strongest measure that can be taken to avoid infections and diseases in babies.
So some folks do best with pumping in general, so that can also be encouraged.
The best side hustle to start in 2022 is not by doing e-commerce, real estate, or writing blogs that no one's ever going to.
Hello and welcome to Baby Health. I am Dr. Sandeep Gupta, Senior Pediatrician and Child Care Expert. Today I am going to speak about the role of breastfeeding in childcare. So I'll start by saying that breastfeeding is actually the golden rule of infant nutrition, and exclusive breastfeeding is recommended till the age of 6 months by World Health Organization, Indian Academy of Pediatrics, because breast milk has all the nutrients like calories, protein, fat, and even water in sufficient amount to support the baby's growth and development till the age of 6 months. So, which is very important for baby's growth. And breastfeeding can be continuous after 6 months also till the age of 2 years, along with the semi-solid food, which is called complementary feeding. And breastfeeding has multiple good nutrients which help in brain development also. Like example, DHA, so which helps in brain development of the baby, and it is related to higher IQ in children who are actually breastfed. So apart from the nutritional value, breast milk also has a role in immunity development. So what I say personally is the breast milk is a ready-made immunity. What happens when the baby feeds mother's milk? Mother's antibodies are the particles which actually help us in killing the bacteria and viruses from the outside environment which come into our body. So these antibodies are transferred through the mother's milk to the baby. So it helps in protecting the baby from infections, which is very important because babies are very vulnerable. Their immunity is not mature. At an early age, these antibodies coming from mother's body is protecting the baby. Apart from the antibodies, there are other substances in the breast milk which actually protect the babies from infection. So there is something called lactoferrin that also is helpful in protecting bacterial infections. Apart from that, there is multiple roles of multiple benefits of breastfeeding. Like because breastfeeding is coming directly from the mother, it is clean and hygienic. So it is actually not any risk of contamination. Definitely there will be a small but very there will be always chances of contamination. So which is very vulnerable. So baby can get infected. That's why it has been seen both this combined role of getting a better immunity and breast milk being clean and hygienic. There is a lesser chance of your baby getting infections like diarrhea, pneumonia, lower respiratory tract infection, and ear infections if your baby is exclusively breastfed. So apart from these benefits, actually breast milk also has some long-term benefits. So it has been seen The babies who are actually breastfed, they develop less amount of allergic disorders like atopic dermatitis, asthma in future life, as well as the risk of obesity, type 2 diabetes, metabolic syndrome. This is also less in breastfed babies. And there are multiple benefits of breastfeeding to mothers also. So what happens is when a mother actually does exclusive breastfeeding, there are certain hormones released in their body, like oxytocin, which is a hormone for feeling happiness. So mother feels less stress when they are doing exclusive breastfeeding. They feel relaxed. They have a sense of bonding with the baby and well-being. So it has been seen the mothers who do exclusive breastfeeding, they have lower incidence of postpartum depression, so which is very beneficial. And apart from that, it also helps in reduction of the uterus size. Uterus is the organ in which baby resides in the abdomen during the pregnancy. So uterus swells up multiple times its size during the pregnancy to accommodate the baby. So once the baby is delivered, uterus has to go back to its own pre-pregnancy size. So that is helped by the breastfeeding. So breastfeeding actually causes release of oxytocin. So the oxytocin makes the uterus contract to go back to a previous size. Apart from that, because of this uterus contraction, postpartum bleeding risk is also less when you do breastfeeding. And there is also multiple other advantages like postpartum weight loss. So what happens is during the pregnancy, mother gains around 10 to 11 kg of weight, which is easily said if you do breastfeeding. And it has been seen the mothers who do breastfeeding throughout their life cycle, they have a lower incidence of ovarian and breast cancer. So breast cancer and ovarian cancer risk will be less if you do continuous breastfeeding. And one more very important in the Indian context is that if you do breastfeeding, there is something called lactational amenorrhea, and which provides natural contraception. So there will be spacing between the two babies, and that allows for one baby to get enough support and care from mother before another baby comes into the mother's body. So which is very important. So overall, I will say that breastfeeding is the golden rule of infant nutrition, and it is liquid gold for the baby. It is delivering to the baby at the right temperature. So because it's coming from mother's body, it is at the right temperature for the baby. If you prepare artificial milk, what happens? Artificial milk is too hot, too cold, baby may not like it. But mother's milk, if you directly feed from the body, it will be at the right temperature for the baby. It gives immunity, it has long-term benefits. So I will always urge you to continue breastfeeding and take support if you are having any difficulties for breastfeeding. I have made a video for mothers who are feeling that they are having less quantity of milk. So you can watch that video. If any queries or doubt, you can ask me. If you find this video helpful, you can subscribe to my YouTube channel. You can comment in comment section. You can put your questions. I'll try to answer all the questions possible. Thank you for listening to us.
All right, so you can see the videos go on forever about breastfeeding. Antibodies are passed on from the mother that provide greater protection against infections and sudden infant death syndrome, long-term benefits against illness and diabetes, even leukemia, high blood pressure, and asthma. But less than 40% of babies aged 6 months or younger are exclusively breastfed internationally. It is a lot of hard work. So, there's also an epidemic of SIDS I wanted to cover, mostly in the Midwest. So, and about a year ago, they thought they had found why there was SIDS. So here's the causes of SIDS.
Today's topic is sudden infant death syndrome, or or SIDS. Sudden infant death syndrome is defined as the unexplained death of an infant less than 1 year of age. SIDS is suspected when a seemingly healthy infant is found dead following a period of sleep without any sign of distress or serious illness prior to the incident. SIDS may occur in infants and children lesser than 16 months, but risk peaks in infants between 2 and 4 months of age. Also called crib death, SIDS is considered the most common cause of death for children under the age of 1. Causes. The cause is unknown. However, SIDS may be associated with abnormalities in the part of an infant's brain that is responsible for sleeping and arousal from sleep. A combination of factors can make an infant vulnerable to SIDS and may vary from child to child. Some of these factors may include respiratory infection, low weight at birth, sleeping on the stomach or side, premature birth, overheating, unsafe or old crib, sharing a bed with parents or pets, the family history of SIDS, sex, males are at a higher risk than females, race, babies of African American and Native American descent are twice more likely to die of SIDS than other races. Babies who live with people that smoke are at a higher risk. The mother during pregnancy may affect the baby's risk of SIDS, especially if she is a drug or alcohol user, cigarette smoker, under the age of 20, has inadequate prenatal care. Symptoms. SIDS doesn't have any noticeable symptoms, as it happens unexpectedly and sudden. Diagnosis of this death can be determined through process of investigation. This investigation may involve collecting information and conducting tests and procedures. The certain investigation that helps in determining SIDS death may include post-mortem laboratory tests that are done to rule out other causes of death, an autopsy to determine the exact cause of death, a thorough investigation of the crime scene. Parents, caregiver, and other family members may be interviewed. Items may also be collected. Reviewing the family or medical history. This allows knowing if there has been a previous history of unexplained infant deaths, cardiac death, and genetic disorders. Prevention. There is no which are at risk of SIDS, but you can help your baby and reduce the risk of SIDS by following these precautions. Breastfeeding your baby. Placing your baby on his or her back to sleep, both at night and during nap times. Keeping your baby's face clear of coverings. Avoid overheating your baby. Have your baby sleep in your room with you, but alone in a crib or other structures designed for infants. This should be for at least the first 6 months or a year. Don't allow smokers around your baby. Firm sleep surface should be used in your baby's sleep area instead of fluffy, loose beddings such as lambskin. Immunize your baby. Educate daycare providers, babysitters, grandparents, and other people who care for your baby about the risk of SIDS. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest videos.
So that is one of the challenges with SIDS. There's quite a bit of commercials and things.
I remember feeling a little bit anxious on the day he was born.
The 9 months leading up to his birth was just full of anticipation and excitement.
It was just so thrilling, and I mean, it was scary, but
She was perfect. 10 fingers, 10 toes.
when he was born, it was just amazing to hear his cry and see his face.
oh, the coolest thing was just how in love I was with him.
I didn't have any worries besides what diapers I was going to choose.
Everything was great. She was beautiful.
When we found Charlie, we knew something was wrong.
I went to work that day and everything was fine. I expected to come home and everything be fine.
Everybody went to sleep. She was already asleep.
I sat down on the couch, was watching TV, and I nodded off to sleep with Charlie sitting on my chest.
I woke up to my baby not responding.
No one found him until, it was too late. He was blue.
Cause I had tried CPR on her.
I wasn't at the point where I was believing that this could be really happening to our baby.
So I mean, I'm still thinking like, okay, maybe she's just gonna wake up out of it. And then when ambulance came, I learned that it was a co-bedding accident where her father fell asleep with her on the couch and she was accidentally smothered.
It wasn't until we had to make the call to stop CPR that I knew that he was gone.
When my daughter passed away, every dream and hope that I had for her also was gone.
Even though my wife was a kindergarten teacher and I'm a pediatrician, it happened to us, and it can happen to anyone.
You blame yourself, you go through what is and why, but
We know that there are things that you can do to lower your risk for SIDS deaths.
baby must sleep alone. I always sleep on her back and I always sleep in the crib.
ABC is a great way to remember it. Alone back crib. A stands for alone. The baby needs to be in their crib without bumpers and blankets and stuffed animals.
Yeah, a lot of parents say that I've had, 3 children already. They've slept in bed with me. This was really beneficial for mom bonding to baby.
But the evidence suggests that it's not safe.
The baby needs to be on their back.
Because when babies sleep on their side or on their belly, their face is up against the mattress or up against a pillow. And as a result, they can't breathe.
And the baby needs to be in their crib, in their own space. It's important that the parents follow the ABCs of safe sleep, but it's also very important that the parents tell everyone and anyone else who's going to be with the baby about these rules. Our parents didn't have these precautions to go by. And so if they revert back to what they did with us, then they're not following what we know now.
The message has changed because the science has told us that something's new.
Whether it's grandparents or daycare workers, babysitters, it's really important that that person put the baby alone on their back and in a crib.
If they can't do what's expected of them, then they don't deserve to watch the baby.
Because this is your child, and it really matters how this is handled. We share information about the best diapers to buy and the best food to feed our baby. So we should also be sharing information about safe sleep.
You're gonna be tired and the stress level is gonna be high. You just have to have your network of support, family members, friends, neighbors. There's a community of people out there that can all help. I don't want to scare anybody. I just to let people know it's very real.
Who wouldn't want to do something simple to save their baby's life?
I think if I could tell a new parent anything, it would be, I know it's hard. I've been in your shoes, but keep your baby safe. Put your baby alone on their back in a crib for every single sleep.
So as you can see, a lot of folks have been challenged by that. And some new advice comes out and they're trying to push the alone back in crib. So this is one of the...
You might have heard that breastfeeding is challenging. It's so much worse. Thankfully, I found LaVie's warming lactation massager. I freaking love you.
What'd you say, honey?
Nothing. Trying to feed your baby can be messy.
Oh, okay. Frustrating.
Ah! Strange.
Big boo.
Little boo. So let LaVie's warming lactation massagers make your breastfeeding journey better. The lactation massagers use heat and vibration to improve milk flow, reduce nursing time, and provide relief. whether you're nursing or pumping. The truth is, breastfeeding isn't easy. It's for you. It's your breast friend. With LaVie, it gets easier. Get yours at LaVieMom.com. For a limited time, save 25% when you bundle. Plus free shipping on U.S. orders over $25. It's the best deal ever. I'm coming back around.
Jessica Swinston and her fiance make sure their 2-month-old baby girl Malia is close by for bedtime.
So we can see her, keep an eye on her, listen to her breathing.
And that's right in step with new guidelines from the American Academy of Pediatrics to help decrease the chances of sudden infant death syndrome and other sleep-related deaths. The group recommends infants share their parents' bedroom for at least the first 6 months of life, and ideally for the first year.
The studies that were done looking at the reduction in risk of SIDS really were done throughout the first year of life, and we know that reduction can be as much as 50%.
The recommendations continue to remind parents that babies should be placed on their back on a firm mattress in the crib or bassinet, and there should be no blankets, bumpers, pillows, or toys.
Dr. Lori Feldman-Winter says breastfeeding is also recommended.
Exclusive breastfeeding can reduce the risk of SIDS by as much as 70%.
Also recommended, offer a pacifier at naps and bedtime, and babies should get plenty of supervised awake tummy time to promote development.
The smile.
Malia's parents are doing everything they can to keep her safe, including giving her her own space.
We never let her sleep in the same bed with us. It's too dangerous.
That way everyone sleeps better, but only for 3 to 4 hours at a time. Marley Hall, CBS News, Clementon, New Jersey.
All right, so you see a lot of the different things that happens with SIDS and some of the suggestions from it. Here's some of the nursing studies from it.
Everybody, we're going to just go ahead and jump into our series on oxygenation, which is going to include sudden infant death syndrome and RSV, which is respiratory syncytial virus. The first lecture is going to be on sudden infant death syndrome. By the end of the lecture, you should be able to identify the pathophysiology, prevalence, and clinical course of sudden infant death syndrome, which is also known as SIDS. You should be able to identify risk factors associated with SIDS, establish priorities of care for infants at risk for SIDS, devise a nursing care plan using best practices for infants at risk of SIDS, discuss therapies to monitor infants at risk for SIDS, create a teaching plan, incorporating preventative measures for families with infants at risk for SIDS. You should also be able to implement culturally appropriate client-centered care, determine data to document on an infant at risk for SIDS, implement the use of information technology, relate principles of quality improvement while correlating national safety goals and collaborating with members of the interdisciplinary team. I'm going to go ahead and apologize that once again, this is just a kind of a basic voice over PowerPoint. I did try to do something a little more creative where you could see my face and recorded that with Zoom, but it did not seem to be compatible when I had Miss Navarro test it out. So for now, you're just stuck with my voice, sorry. So let's talk about what is SIDS. I'm sure that most of you all have heard of SIDS. It's a devastating event that happens to families. And it's often without any kind of warning. There's really, a lot of theories on why SIDS occurs, but they really don't have a pinpoint cause of it. So SIDS or sudden infant death syndrome is the unexpected sudden death of an infant under 1 year of age that remains unexplained even after an autopsy and thorough medical investigation. So they've ruled out any other cause that they can for the death. And when that occurs, then they determine that it was SIDS. SIDS is the leading cause of death among babies who are between the ages of 1 month and 1 year of age. Most of the time, these cases are going to occur between 2 to 4 months of age. That's really the critical time period that most SIDS cases occur. And that's an important thing to remember. In an effort to reduce cases of SIDS, back in the 90s, there was a campaign that was developed called Back to Sleep. The campaign now is known as the Safe Sleep Campaign, but it preaches the same message, which is to put your babies on their back to sleep. Babies do need tummy time, but that time needs to be when mom is awake, dad is awake, baby is, just kind of hanging out and playing in the floor. You can let the baby you can let the baby lay on the stomach and kind of build those neck muscles up. But when the baby is sleeping, the baby needs to be on his back. So currently, SIDS research focuses on 3 kind of general areas that they feel like play a role in the occurrence of SIDS. And that includes the infant having some type of vulnerability, that the SIDS incidence occurs during a critical developmental period, and that there is some kind of outside stressor that contributes to the event. So they do know that there's a critical developmental period, right, that SIDS typically occurs, and that's because 90% of all SIDS deaths have shown to occur between 0 to 6 months of age. And remember, the peak is 2 to 4 months. But you have this critical time period in the first half of a child's life that they are at especially increased risk for SIDS. We know that during that first 6 months, that infants are constantly growing, their brains are growing, their whole neurophysiological characteristics are all developing, and this is also important during this critical time period. That means that the baby, the baby has some kind of subtle defect that they don't really know what it is, but whatever it is causing that baby to be at an increased risk for SIDS. And then you have your outside stressor, which is that challenge that because the infant is vulnerable, that child cannot respond like a healthy infant would. So maybe this vulnerable infant has an upper respiratory infection, or maybe the vulnerable infant lives in a home where there's a lot of exposure to cigarette smoke. Those kind of things are outside factors that contribute to the cause of SIDS. And again, this goes over the same 3 areas, and this is called the triple risk model or the triple risk theory. It's just what we put together based on years of looking at causes and what conditions have happened in these infants that have died from SIDS, and they're finding these 3 common areas amongst these cases. So that the infant was vulnerable, there was some kind of underlying defect or brain abnormality, that this event occurred during the critical developmental period within the first 6 months of life. Although, it can occur in the first year, but typically, like I said, they're going to find that this occurs in the first 6 months of life, most especially stressor, whether it be the baby's sleeping on the stomach, the baby's overheated, the secondhand smoke, upper infection, what have you. So according to this particular triple model theory, all 3 factors need to be present in order for SIDS to occur. So let's think about it. You have an infant who is asleep. Now, this particular infant, unbeknownst to us, has a physiological vulnerability, okay? Something that makes this baby more vulnerable to diminished oxygen, maybe on the stomach, okay? And that normal environmental stimulus that would cause the baby to respond and to take a breath and to change and move and all of that to be able to breathe properly, that stimulus does not occur in this vulnerable infant. So not only is that a factor, but then if you think about if this particular baby is sleeping on their stomach, what about all that trapped air that the baby's just rebreathing over and over again? That's also contributing to the baby being vulnerable and being at risk for poor oxygenation. Consider too that prone sleep is typically deeper and more prolonged than supine sleep. And like I said, you know, in a perfect world or in a healthy infant, this wouldn't necessarily be a threat because the healthy infant can respond. And the healthy infant would recognize that they need to readjust their position, maybe kind of stretch out and get the heavy blanket off of them. But there are factors that we don't know, so you can't assume that a baby is healthy because we do know that there's underlying things like brain abnormalities or genetic mutations or genetic polymorphisms that you may not be aware of that can cause the baby to be at risk for SIDS. So that's why we consider all babies to be potentially at risk for SIDS. It's just that this theory has found that there are 3 conditions that seem to present each time a case of SIDS occurs. So what risk factors do babies have for SIDS? Babies who sleep on their stomachs are at risk. Babies who sleep on soft surfaces, such as an adult mattress, a couch, a chair, or either under soft coverings are also at risk. If they sleep on or under soft or loose bedding, they too are at risk. Maybe they get too hot during the sleep time because the thermostats are set too high, they could be at risk. And if they're exposed to cigarette smoke, whether it be during the pregnancy or maybe it's in their environment after birth, in the home, in the car, bedroom, what have you, they too are at risk. Research has shown us that formula-fed babies tend to have more occurrences of SIDS than babies who are breastfed. So breastfeeding is a protective mechanism against SIDS. We also know that children or babies that sleep in an adult bed with parents, other children or pets, this is especially dangerous because it too, it kind of puts the baby in a situation where they are more vulnerable to being covered by a blanket or a quilt. They maybe if the adult has smoked, recently had alcohol, or is tired, the adult is not going to be as alert to protect the baby from any kind of event that could risk SIDS. If the baby is sleeping with more than one bed share, so mom, dad, and baby are all in the same bed, that increases the risk of SIDS, as does a baby being younger than 11 to 14 weeks of age sleeping in an adult bed. As nurses, what is our role? What are we supposed to do about this? We know that, you know, we don't really know exactly what causes SIDS. We know some things that contribute to it, but what can we do to help reduce SIDS? Well, first of all, we need to be aware of what the risk factors are. If you know that you're taking care of a family and the parents are both smokers, that should be a red flag that this family needs specific information. All families should get information on SIDS, but this family, if they have especially high risk factors, you need to let them know that. They may not know. We also need to provide education, again, to all parents, but especially to those at high risk, for what is considered safe sleep. What are measures that they can do easily at home to reduce the chance that their baby has a death from SIDS? Many times parents are young, they've maybe been influenced by their culture, or they've been influenced by their family members, and they don't know any better. So we have to educate them on what is the correct thing to do. Yes, Grandma Susie may have put you on your tummy to sleep and you turned out just fine. But guess what? When we know better, then we need to do better. And research now has evidence that this isn't a protective mechanism against SIDS. So we need to teach our patients to put their babies on their back to sleep and tummy to play. Now, suppose you are an emergency room nurse, and you are working maybe the early morning shift, maybe you're still working at 6 or 7 in the morning, and a family comes in and they just experienced losing their child to SIDS. Then you need to be that person who can provide support to the family. You need to be familiar with area resources so that you can make referrals for this family. They probably are going to need some kind of bereavement counseling. These families often feel a tremendous amount of guilt. You're going to need to allow them time to work through that. You're going to need to allow them time to spend with their baby. That's the utmost priority. You know, we can't decide what's best for these families. We can educate them and we can prepare them. But if they have a child that passes from SIDS and they want to spend time with that baby before the baby is taken to the morgue or to the funeral home, then you need to allow that to happen. So we have to educate our families because we do know that education is the most effective tool we can provide our patients to prevent SIDS. Families and parents, they listen to healthcare providers, whether it be the physician, midwife, nurse practitioner, their nurses. They respect us. We all know that nurses especially rank very high as far as the most respected profession. They take what you say to heart and they believe you when you tell them this is what they need to do. So we need to remember that we are a very effective tool in preventing SIDS just by educating our patients on these factors and what to do at home. Parents are going to be more likely to place their baby on the back to sleep if we suggest it versus a family or friend. It's important as nurses that we stay in continuing education. There's always, lots of times, there's free models on SIDS and the changes and the research that is being discovered that you can find on different sources, whether it be Lippincott or WebMD or what have you. There's many resources and you need to stay abreast of that. Even if you're not a maternity nurse or a newborn nursery nurse, everybody that works with families needs to be aware of how to educate families on prevention of SIDS. It's also especially important to educate families on the proper use of pacifiers because we know that pacifiers can help prevent SIDS. Now, there is a little side note to this. So if you have a family who's breastfeeding, remember breastfeeding is a protective mechanism against SIDS. Research has shown that pacifiers that are introduced too soon can actually harm the baby's ability to breastfeed. So we want to educate these breastfeeding families that they do need to introduce a pacifier, but they need to wait until 1 month of age because they want to make sure that that breastfeeding relationship is established. We also can remind them that, hey, you're protecting your baby against SIDS by breastfeeding, and that SIDS generally doesn't occur in that first month, so that it is completely, rational to hold off until that 1 month period to introduce that pacifier. But for our formula-fed babies, they can use the pacifier sooner than 1 month. Pacifiers are, actually a really good thing that you can maybe mention if you have families asking what kind of things do they need to prepare for their baby. They may want to go ahead and ask for some pacifiers, not to use it from, the jump start, but they can also remember that just because we're encouraging pacifiers doesn't mean that they have to keep them in the baby's mouth 24/7. Pacifiers are appropriately used when the baby's allowed to use it at time of sleep. If that pacifier is in the baby's mouth when they go to sleep and it falls out, then guess what? You leave it out. You don't force the pacifier on the child. It's just a way to keep the baby in a little bit of a lighter sleep so that they, to prevent that deep, deep sleep where a SIDS typically occurs. So, soapbox is over for that. Just know that pacifiers are a useful tool, especially if you can wait for a breastfed family till 1 month of age and older. And like I said, formula fed babies, there's no time restriction, but they should be encouraged as a factor to help prevent SIDS. We need to protect pregnant women from secondhand smoke. If they are smokers, cut back, reduce their smoke outside the home, not around the baby, those types of things. And again, assess for cultural differences, because we do know that in different cultures, they have different sleep habits. Find out what the normal is for their culture. Talk through that. Educate them on why this is what you're recommending, and see what you can come up with to make this work for that particular family. And especially you need to ask who's caring for the baby at home. Is there smoking at home? Where's the baby going to sleep? We take for granted that these babies go home and have a nice crib to lay in. That's not often the case. Some families can't afford to buy a crib. So baby may very well end up in the bed with mom. Maybe mom is staying at home with grandma and 2 or 3 other brothers with their 2 or 3 other children, and they're in one room together, this mom and baby, and they don't have anywhere for the baby to sleep. So we need to talk through that situation, discuss what are safe options for that baby that don't include that baby sleeping in that adult bed. Now you're going to see a video, and hopefully you'll be able to play this video without any issues once you go back and watch this. If for some reason you're unable to play the video, just go to your Google search and type in "safe sleep for your baby," NIH, and that should pull up the video for you. But this is a very helpful video, and I would make sure that you watch it completely. There may be information in there that you will need to know for your test. This image is just a representation of what the ideal room would look like that a baby sleeps in. So a baby would preferably be in the same room as the parents. However, not sleeping in the bed with the parents. The baby has his own sleep area that is free of any extra blankets, soft stuffed animals, soft pillowing, or any additional soft or loose items. You also notice that the baby does not have bumper pads. Bumper pads are no longer recommended. They prove to be a suffocation risk, so you do not want to have those in the crib. You want to allow the baby to sleep in something like a little wearable sleep sack. You don't want to have loose blankets or over bundle the baby. Always put the baby on the back to sleep. Encourage people to avoid smoking around your baby. Also, ensure that the baby is in his own area, is not sleeping in a couch or a chair, whether he's alone or with you or anyone else. And he should also not be sleeping in an adult bed. That mattress needs to be firm and it needs to be flat. And like I said, it is a good idea to allow the baby to sleep in the same room as the parents, if at all possible. So we need to remember too, like I said, that these parents, you assume that the baby's going home to a nice cozy room like this with a clean, fresh made crib mattress and a crib, but this is not always the case. So we need to have conversations about where the baby is sleeping with the parents. This is the resource that I used to find most of the information in the PowerPoint. Your textbooks have little to any information on SIDS that I was able to locate. So what I would encourage you to do is to study these PowerPoints for your exam. You can also go to the website that is located in your discussion forum, that the Safe Sleep Room. That website has some additional information throughout it about SIDS. And I would also encourage you to check out the National Institute of Health and look up anything about SIDS related on there. If you do those things, then you shouldn't need to look at any other textbooks. SIDS is pretty straightforward. So just if you have questions or anything that's confusing, just let me know.
All right, so there's a lot of stuff on the SIDS. And some of the folks challenged by it
On October 8th, 2020, my daughter Nomalee was 9 weeks old and 3 days. There was nothing out of the ordinary that day. In fact, it was one of the best days that we'd ever had together. She slept so well. She was comfort feeding. I was breastfeeding her, and it was my favorite thing to do. It took us a while to perfect it, but we finally got there, and it was the best feeling in the world. In fact, she looked up into my eyes while she was breastfeeding, and that was the first time she'd ever done that. She usually stared kind of past my arm or into my armpit area. But she finally just looked up into my eyes, and I just remember thinking, yes, we made it, we did it. I just thought that everything was going to be perfect for me. I was watching a TV series while Noah was sleeping in my arms. So I was up quite late that night. Her dad was supposed to finish work at 10:30 and be home by 11:30 midnight, but it was about 1 a.m. and I was getting a bit worried. He wasn't home yet and he wasn't answering his phone. So finally he called me back and he was almost there, which was great. So we had both had a late night. At Noah's 3 a.m. feed, she would usually feed for about 10 minutes and then I would be able to rock her back to sleep straight away, pretty much straight away. And I was really tired, so I was eager to get her straight back down to the nap rather than as she drifted off to hold her in my arms, which is what I often did, just to make sure that she was in a deep sleep. This time I kept trying to lay her down, and as soon as I would lay her down, she knew she wasn't in my arms again, and she would wake up and she would fuss, and so I would need to try and settle her on the breast again, and then try and put her down. And I did that about 3 times. My husband woke up and he offered to take her to settle her and put her to sleep in the lounge so that I could get some sleep. And at first I said no. I knew he was tired too, and I knew that I could always get her back to sleep quicker than anyone else. But he insisted, and I was tired, so I left. And he was walking out the door. I remember thinking, tell him to bring her back into the room once she's asleep so I can put her in the bassinet. And at that point, she just started to grizzle. She started to cry. And so I didn't tell him that because I was being selfish. I wanted to sleep. So they were in the lounge and it was about 4 o'clock or between 3:30 and 4 o'clock in the morning at that time, and I went straight back to sleep. So at 7 a.m., I woke up to Brogan yelling, and when I first heard the noise, I sat up and I stopped my sleep timer, and I was well rested, and I thought, oh, she must be hungry. It's time. It's been 3 hours. She's ready to feed. And Brogan came running into the room. Noah was really limp in his arms, and Brogan was screaming, and he was saying, she's not responding, and I was so calm. I said, calm down, hun, just lay her down. And straight away I started CPR. And I said, call an ambulance. And I was still calm because I thought, like everything else, I was just gonna fix it. She was okay, she had to be okay because I was gonna fix it.
Arby's showed us a great weight when crafting its deluxe Wagyu steakhouse burger. And with great weight comes great responsibility to make irresponsibly huge burgers. Arby's.
Middle, but this is
Jupiter.
I was treated in my cheeks and in my chin.
And this.
SIDS.
So I started CPR, and as soon as the emergency number went through, I told them what was happening, and I told her to tell me how to do CPR properly. And no one was laying on the bed at that time, and I hadn't thought to put her on the floor, so it's about 30 seconds to a minute that I was doing it on the bed, which is obviously not effective. So we laid her on the floor, which is at the foot of our bed. And her face, she looked so peaceful. She always sat with her mouth open and her beautiful eyes. She just looked so calm, and she felt a little bit cold. There was a moment when Brogan was kind of tapping her face, and he pulled back her eyes to try and open her eyes. And she was just staring blankly ahead. There was nothing there. There was just nothing there. And at that moment, I panicked. I started to panic a little bit. I don't know how long I was doing CPR for, but the firemen.
So, as you can see, it's definitely a challenge that a lot of people struggle with. So it's uninspected death of an infant for which no physical cause can be found. Most common cause of death in the first year of life, it's 1 in 400 babies. African American babies are 2 times more likely to die from sudden infant death syndrome than white babies. Several infant and parental risk factors. The believed causes are changes in the infant's airways, viral infection, or sleeping on their stomach. So that's why they say alone and back and crib. So there's nothing that could occur that way. And then the back to sleep campaign. Babies are safest when they sleep on their backs. And then some of the psychological dimensions, so cognitive development, information processing with kids. There's intelligence, measured in multiple areas, be it problem solving, language, attention, memory, and information processing. Children increase cognitive development through learning. Some of the problem solving, so manipulating objects to achieve a specific goal. At 1 month, they follow their face. At 5 months, turning the head to look for a drop spoon. At 7 months, they can find a partially hidden object. At 10 months, uncovering a toy cloth to find the toy. And then at 12 to 18 months, they don't understand invisible displacements. And then at 2 years, has full object permanence, can hold an image in person in their mind, know where the cookies are kept, etc. And then how does cognitive learning occur? So with Piaget, their sensory motor stage is birth to 2 years. Through circular reactions, they develop from random reflexes to intentional goal-directed behaviors. How do we assess it? So assessing the learning with the babies. How do they process information? They observe how long an infant will look or fixate on something. Interesting and not be distracted. So habituation is where they become uninterested in a stimulus and respond less to it after it's repeatedly presented to them. Dishabituation is increased responsiveness after a change in stimulus. Babies pay more attention to stimuli they haven't seen before, things they have control over, and events they didn't expect to happen. And some of the implications are those that habituate faster may be brighter at age 12. Also, a 6 to 7 month old, they display categorization and perhaps have an innate sense of how the world works. Some of the other cognitive development language milestones, representation of thoughts and ideas using culturally agreed upon arbitrary signals for the exchange of ideas. So expressive is what they say. Receptive is the ability to understand. Assessed through response to a request. Ability to learn is innate, but environmental exposure is essential. Interventions for lower socioeconomic kids include videos and reading. How should we communicate with babies? So here's some other language milestones. So at birth, it's crying. At 1 to 2 months, they begin cooing. At 4 months, laughing. 6 months, babbling and gestures for up. 9 months, mama and dada, language specific. 7 to 11 months. At 10 months, the waves bye-bye. And then at 12 months, first words and then pointing. That's some of the communication stuff with kids. Some cognitive development language milestones. So at 15 months, they can shake their head no and use 3 to 5 words. Holophrasic speech, 1 word means a whole sentence. Overextension, so like dog, and that means the entire category of animals. Or like my kids will say bee, and that could cover an ant or a fly, or they might say fly. Then at 18 to 24 months, pronouns like me, and they have a vocab of 50 words. Telegraphic speech, they combine 2-word phrases. Noun, verb, such as more drink. At 6 months, they have a few other things like turning to sound and voice. At 9 months, lack of babbling, consonant words. At 24 months, failure to use single words. Some of the social and emotional stuff. So at 1 month, they discriminate to the mother's voice. At 2 months, reciprocal smiling. At 4 months, stops crying when the parent's voice is there, and then even spontaneously smiles. Monitoring, social referencing for emotional information. At 9 months, separation anxiety orients to their name. At 12 months, looks at stranger for cues. At 15 months, empathy and hugs. 18 months, pretend to play. Fake emotions, more complex emotions like shame, guilt, and pride. And then at 20 months, kisses with a pucker. Emotional expression in infancy is predictive of sociability in adulthood also. With the temperament, some of the characteristic patterns in which an infant responds to and interacts with the environment is biological. 9 dimensions of the temperament. 3 types of children: easy child, slow to warm up, difficult child, and then behavioral inhibition. Implications for adult functioning, and then it's important to have the right match from the environment for each temperament, such as goodness of fit, etc. Now, with attachment disorder forming a strong emotional tie to a caregiver, parents and child are biologically programmed to form a close bond, and that's by Dr. Bowlby. Also, it's easier when a baby is responsive to adult because it creates a positive feedback loop. Implications for functioning, interpersonal skills, self-control, and then school for performance. Strange situation assesses the attachment type. So that's the next one I wanted to show. They have quite a few in the strange situation. And this researcher came from Dr. Bowlby, and here is one of the different things they did with Mary Ainsworth from 1969's Developmental Psychology.
At Amica, we provide you with something more than auto, home, or...
In 1969, American psychologist Mary Ainsworth gave developmental psychology a new procedure for studying attachment in infants. She called it the strange situation classification, and it's widely referred to as simply the strange situation. As an adult, you know when you've formed an attachment with someone, you know how it feels, and you know how to express your feelings in words. However, when it comes to babies and young children, they haven't yet developed these skills, and therefore researchers must turn to more subtle techniques, such as the strange situation, which measures the security of an attachment in 1 to 2-year-olds. A 20-minute participatory observation, during which the researcher observes the infant's behavioral responses to a series of scenarios. Ainsworth's strange situation includes 8 stages, each lasting roughly 3 minutes. To start with, the mother, baby, and researcher are all together in the room, a small, neutrally coloured space with some toys for the baby to play with. The experimenter leaves after around a minute, and the mother and baby are alone for approximately 3 minutes. In this stage, researchers are watching to see whether the child is confident to explore the new environment, or whether she stays close to the mother. A stranger joins the mother and baby in the room. The researchers record the baby's response to this unfamiliar newcomer, who is left alone with the baby when the mother leaves the room. At this stage, the researchers are observing the baby's behavior for signs of separation anxiety. 3 minutes later, the mother returns, and the researchers observe for the baby's reunion response. The stranger leaves the room. A few minutes more, and the mother leaves the room too, leaving the baby alone for the first time in the experiment. The next person to enter the room is the stranger. And finally, after 3 minutes, the mother returns and the stranger leaves. All in all, a perfectly strange situation for all involved. So, what were the researchers measuring? When the mother was in the room with the baby, they scored the infant's behavior on 4 measures. proximity and contact seeking, contact maintaining, avoidance of proximity and contact, and resistance to contact and comforting. The baby's exploratory behaviours were also recorded as she explored the environment. Ainsworth reported that infants display one of 3 attachment types. Securely attached infants showed distress when separated from their mother, were avoidant of the stranger when alone, but friendly in the presence of their mother, and were happy when the mother returned from outside the room. 70% of children studied fell into this category. 15% of children demonstrated an ambivalent attachment with their mother. These children showed intense distress when the mother left the room and demonstrated a significant fear of the stranger. When the mother returned to the room, ambivalent children approached the mother but rejected contact. Ainsworth reported that a final 15% had an avoidant attachment style. Such infants show no interest when the mother leaves the room and play happily with the stranger. When the mother returns, avoidant children barely seem to notice. In 1990, Main and Solomon added that a very small percentage were inconsistent in their behaviours and defined this attachment style as disorganised. Ainsworth's caregiver sensitivity hypothesis suggests that differences in infants' attachment styles are dependent on the mother's behaviour towards the baby during a critical period of development. If you enjoyed this video, please click the like button and share it with others. If you haven't already, make sure you're subscribed to
So that's one of the strange situations. There's quite a few that break it down with Mary Ainsworth, and her advisor was John Bowlby. He died about 30 years ago.
Breastfeeding is natural, loving, and brutal. Beautiful. Beautiful. Thankfully,
welcome back, everybody. Today I want to introduce you to one of the most important females in psychology. She might have put children through some stressful situations, but she opened our eyes to the importance of primary attachment figures. Bowlby is normally the person you think about when it comes to attachment. However, it was his colleague Mary Ainsworth who came up with the widely known test for attachment, the strange situation. The test is devised of 8 sections. Number 1, the baby and mother introduced into the room by the experimenter. Behind a double-sided mirror, the experimenters are primed. They're ready to observe behaviors of attachment seeking, of resistance, and of exploration. The next phase is number 2. The baby is placed in the direction of the toys and the mother starts to read a magazine. The experimenters are measuring the child's ability to use the parent as a safe base in which to then explore the shining toys in the room. Number 3, the stranger enters. Bowlby theorized that the baby has an inbuilt alarm system towards the strange, and that from the ages of 6 months through to 12 months, the child is building a catalogue of what is familiar experience. Number 4, the parent leaves the room and the stranger stops playing with the child so they can notice the loss of the parent. It is here that the investigators are diligently observing the child to see if they cry or reach out for their parent. They are also observing the child's likelihood to reach out to the stranger in this distressing time. Number 5, the mother comes back in and soothes the baby. Will the baby accept this? A secure baby may smile at the return or need a hug before going back to exploring. The avoidant might not have expressed any loss to start with, and the anxious may be inconsolable or angry. Number 6, once the child has settled, both the stranger and the parent leave. This is the first time in the experiment that the child is all alone. How will they react? All styles are expected to get separation anxiety, but how will they cope with this surge of distress? The baby is observed to see if they move from distress back to exploring the room. Number 7, the stranger then comes back into the room. They attempt to engage with the child and soothe them. The observers were curious about whether the baby needed their secure base to feel confident to explore again. Number 8, the poor baby is then comforted and the experiment comes to a close. Secure attachment. The child is reliably comforted. The caregiver is attuned to their needs and mimics their emotions to show the baby that they are understood. They soothe and show affection through hugs and physical touch. Anxious attachment. The child won't have been actively punished, but the care they are likely to have received from the parent is unreliable and would often not meet the needs of the child. The child will be very anxious because they are not confident that the mother will meet their needs or be present. Once the parent returns, Bowlby hypothesized that the behavior of both rejecting and showing want for contact was due to the child preempting further abandonment. Avoidant attachment. The child has learned to not seek out emotional warmth due to rejection or anger. The mother and child almost make a hidden agreement. The child won't call out or cry as long as they can stay near for protection. In the next video, I want to explain how this all relates to CBT. I also want to talk more about how attachment theory was an initial step towards the development of CBT. I will now be posting every Monday at 6. Please comment below if you have any questions or further thoughts. I'm a keen researcher and would love to hear your comments. Please.
And then here's the last fresh.
The attachment theory argues that a strong emotional and physical bond to one primary caregiver in our first years of life is critical to our development. If our bonding is strong and we are securely attached, then we feel safe to explore the world. We know that there is always that safe base which we can return to any time. If our bond is weak, we feel insecurely attached. We are afraid to leave or explore a rather scary-looking world because we are not sure if we can return. People who are securely attached are said to have greater trust, can connect to others, and as a result are more successful in life. Insecurely attached people tend to mistrust others, lack social skills, and have problems forming relationships. There is one type of secure attachment, and there are 3 types of insecure attachments: anxious ambivalent, anxious avoidant, and anxious disorganized. In responses to distress, the first 3 react organized, while the last acts disorganized. To understand the theory better, let's look at Mr. and Mrs. Smith, who have 4 children: Luca, Anne, Joe, and Amy. The Smiths are lovely parents who cuddle, make frequent eye contact, speak warmly, and are always there for their kids. But one day, Mr. Smith falls very sick and dies. For Mrs. Smith, life now becomes very difficult. She spends all day working, while at the same time trying to care for her children. An impossible task. At 6 years of age, Luca's brain is for the most part developed, his character strong and his worldview shaped. The new situation does not affect him much. He knows there is still always Mum, his safe haven. He feels securely attached. Later, he turns into a trusting and optimistic young man. His self-image is positive. Anne, who is 3, has problems coping with the new lack of attention. To Anne, her mother now acts unpredictably. She is anxious about their relationship and as a result becomes clingy. To get her mum's attention, she has to raise her emotional state and scream. When her mum finally reacts with a predictable response, she herself acts ambivalent and doesn't show her true feelings. Later in life, others think Anne is unpredictable or moody. Her self-image is less positive. Her style is ambivalent. 2-year-old Joe spends his days with his uncle, who loves him, but thinks that a good education means being strict. If little Joe shows too much emotion or is too loud, his uncle gets angry and sometimes punitive. This scares Joe. He learns that to avoid fear, he has to avoid showing his feelings. also in other situations. As an adult, he continues this strategy and has problems entering relationships. His image of himself is rather negative. His attachment is anxious avoidant. Amy, who is just 1 year old, gets sent to a nursery. The staff there is poorly trained, overworked, and often very stressed. Some are outright abusive. Amy therefore becomes anxious of the very people she seeks security from, a conflict which totally disorganizes her ideas about love and safety. As she is experiencing fear without resolution, she tries to avoid all social situations. As an adult, she thinks of herself as unworthy of love. Her self-image is very negative. Her attachment is anxious, disorganized. Our attachment is formed in the very first years of our lives, a time when we are too young to communicate our anxiety, and as a result, can experience high levels of stress. Then our adrenal gland, an organ sitting on top of our kidneys, produces the stress hormones adrenaline and cortisol. The heart rate increases, the blood pressure goes up, and we become alert. If that happens frequently, it is called toxic stress. Toxic because it impairs the development of a child's brain and weakens the immune system. In embryos or at a very young age, toxic stress can even switch the expressions of genes, which can affect our health many decades later. By simulating a strange situation, we can assess an attachment style already by the age of 1. To do this, we let the child play with their mother for a few minutes inside a room. Then the child is left alone. The key moment is the child's reaction when her mother returns. Securely attached children first usually hug their mother, then can calm down and eventually get back to playing. Insecurely attached children can be ambivalent and avoidant. Some can't stop crying or refuse to continue playing. The long-term effects of our attachment in the early years are well documented. Using the theory, researchers at Minnesota University were able to predict already at age 3 if a child would drop out of high school with 77% accuracy. In another study, undergraduates at Harvard were asked to assess how close they felt to their parents. 35 years later, they were asked about their health. 91% of those who said they had a rather broken relationship with their mother were also diagnosed with health issues, including coronary artery disease, hypertension, and alcoholism. For those that had reported a warm relationship, the figure of poor health diagnosis was just 45%. But there is another reason why the early years deserve special attention. They are the starting place for subsequent behaviors. A kid that feels securely attached at age 2 can make friends at kindergarten. Their worldview gets reinforced with every interaction, and they develop optimism. As a result, they make good relationships at school, then at college, and later at work. Highly insecurely attached children can miss out on this opportunity. Psychologist John Bowlby, a pioneer in attachment theory, allegedly said, "What cannot be communicated to the mother cannot be communicated to the self." In other words, those who feel insecurely attached might not quite understand themselves. To get to know who they are and what they feel, they might have to go way back in time.
So that was helpful to break down Mary Ainsworth and some of the research they were doing at the time. So again, attachment is forming a secure emotional tie to a caregiver. Parents and child are biologically programmed to form a close bond. It's easier when a baby is responsive to adults. Implications for functioning later on in life, your interpersonal skills, self-control, even school performance. Here's secure attachment. They use the mother as a secure base when playing. Also, if it's insecure, they do not use mother as a secure base and they're kind of indifferent to things. Also, insecure anxious is like clingy and reluctant to explore or even angry at the mother. So that's some of the stuff we'll see. With self-awareness, sense of a baby as an object by 18 months. Sense of self as an object. Active sense of self by birth has to develop a sense of self as separate from the mother's, and then mother's process of separation, individuation. There's implications for personality assessment and practice there, which we do as social workers too. So some questions for discussion. At what age can the babies obey when not in the presence of others? Some say like 5, 6, or 7 at the age of reason. What role does the process of self-referencing play and self-regulation of behavior? And then the responses from other influences, moral development, but the implications can be to avoid certain responses, like that you got in trouble. Some psychological strengths and hazards being failure to form an attachment is one. Loss of a caregiver is definitely going to cause an attachment problem. Some failure to thrive, like if the child's weight is below the 5th percentile for their age. It could be organic, like underlying medical condition, or non-organic, like psychological, emotional deprivation, or difficult family situations. So here's the circular influences of the baby. Marital interactions, I see what mom and dad do. If they yell at each other, if they hug and love as parents, then the baby's response. And then family stress, how they handle it, if they make it through obscurity or make it more stressful when it goes in a circular path. And we'll get into chapter 5 Thursday, but some social strengths and hazards are the father's involvement, the need for social support. That could even be maternal grandmother, playing with the baby, adoption and birth parents, daycare, if there is infant abuse. Also appropriate environments, like being able to read what the baby needs, like playing at appropriate times. One practice tool is the home observation for measurement of the environment inventory. It's the home inventory. So we'll go over that Thursday. So see you then.